Maybe. All right, we're live. We're live, Lisa.
Hello. Hello,
Oh
friends
wait. Oh wait. Wait.
and enemies. Hello, friends and enemies.
Fellow
Kat, do
friends
you
and
have any
enemies. Hold on.
enemies besides me? Do you have any
You know
enemies
I do.
besides me? Like super enemies, enemies?
You know I have. You know I have a lot. You know it's one of my specialties. Yeah,
Hello,
we can talk
friends and
about that if you
enemies.
want. Yeah. Hello,
I hear
everybody.
it's not streaming. Wait, hang on. We got a warning. It's not streaming. Is it streaming? Kat, did you press the button to stream?
Yeah, I
Says
pressed
it's
the
live.
button. It says it's. Yeah, well,
Mm,
it's fine. Sometimes you got to refresh
mm,
it on the LinkedIn. Yeah.
hang on.
Well.
Hang on. And it still says
Oh.
pre-live here. Give me a second. Wait. We gotta.
Yeah, refresh
No,
it. Melissa,
No,
is it
no,
working?
it's going. It's happening. We're alive. We're live.
Oh, good. As usual, we have a great intro to our talk show then.
Are we live? Hello, friends
Oh
and
my
enemies.
gosh.
And
Oh
enemies.
my
My
gosh.
number one enemy is LinkedIn Live. LinkedIn Live, number one enemy.
LinkedIn Live. We thought LinkedIn Live was going to be the best thing that ever happened to
I
us, and it turns out
know
it is like the
it's
most
not.
not friendly thing ever. Well, here's
Yeah.
what happened to me this week, Lisa. I just got back from an 18-hour bender to New York City.
Oh my god.
It was really fun. I threw a party, as always. I would just like to talk about these parties for a second because a lot of people are like,
You're
"Oh,
so
Kat,
good at this.
all you do is
Yeah.
party," and I go, "Yeah,
Yeah.
listen, assholes, that is all I do, and it's awesome, and I'm better at it than you. But here's why I do them, and I put this in my LinkedIn post earlier. So I've got kids, I've got like a family, and I travel a lot. And you know the number one way to bang out like 15 meetings at once is to have a dinner party. So
Just bring them
I
all together
apologize.
in one
I
place.
apologize to anyone who's upset that they were not invited to these dinner parties. You can be mad about it, but I just feel like you're jealous. So, but I did that. So, and so I met this guy, Rayhan, who's totally awesome. I think you might know him too, Lisa. He's like a startup guy in New York City. He works for Devoted and like 100 other companies. Nadine
Nice.
introduced me to him. And I mean, there's the Node Digital Medicine Conference is this week or was this week, I guess. And so there are a lot of
Cool.
people in the city for that. And he wrote a really cool predictions piece. I know we all love predictions. I know you love
Love
them. But no,
them.
two of his predictions, obviously, I loved because they were
Are
about
we gonna do
um,
predictions? Like, is that gonna be our last meet or our last? Maybe we'll do
maybe
predictions,
that's
right?
what we'll do.
Maybe.
Yeah,
Oh, okay.
maybe we'll do it on Christmas Day. I don't know. But two of his predictions. The one was that there's going to be more investment in Medicaid, which like I feel like has been a thing every year for like the past few years, right? Like everybody,
Yeah.
like I feel like Medicaid isn't like the terrible. I mean, it still obviously needs more investment, but I don't feel like it's like quite the like chasm of despair that it was made
Yeah.
out to be in like 2017, whatever. Hong will tell us about that later, her thoughts on that. And then it was like public health infrastructure will get a lot of attention. I mean, I really hope so. I
I
really
hope
hope
so,
so.
but
But
like I don't. I'm not hopeful. Let's just say I hope so. I'm not hopeful.
yeah, yeah. I mean, I've talked a lot about this with my BFF Chris Klomp, right? He has told me that it's really hard. Like it's hard to see the returns on that. Like if you fund a company that does public health infrastructure for the states, that's like you're competing against like no offense to anyone who works at these companies, like the kind of lame big consultancies that just are going to like build whatever and charge $100 billion for it. And it's hard. So, but there are like I think you can look at public health a different way, right? Like we talked about the community health worker model and like how is that public health? Who knows? I don't know. I mean, I think so. Yes, right. And what is public health really? So I think I'm excited about that. And his other prediction that I mean, I agreed with all of them in principle, but these are the two I cared about. So this climate thing, right? Remember we were talking about climate with Marie Koupoulos, and she was like, "Climate's
Yeah.
amazing, and we should
Awesome.
care, healthcare, blah blah blah."
Yeah. Yeah.
It seems like people are actually talking about it. He's saying that like it's going to no longer be a nascent thing in 2024. I think it's still going to be nascent, but um, I don't know. I don't know.
Well,
But
John.
I met a guy at
Speaking of
dinner last night.
investors, but speaking of investors, John Doerr has like put, I want to say, a lot of his own money into this area, and he has founded a new institute at Stanford based on like focused on climate tech and climate solutions. I mean, like discount as you will, but I know there are people who have lots of money who are thinking about how can we actually do something here for real this time. So we'll see.
Well, I just hope he measures what matters, Lisa. That's all I have to say
You
about that.
measure what matters, John. Who else did you meet?
No,
Who else did you meet?
no,
Yeah.
but I
Who
met
else?
this guy last night. So Dr. John Dayton, who's like a mild celebrity in doctor health tech consulting space, he brought this lovely gentleman, Dr. Let me see his last name, Dr. Chetan Sarubu from Stanford, and he is working on climate and the intersection of climate and health. So we have like two experts. We should get him on a
Nice.
TV show.
Okay. Okay.
Yeah, I didn't want to be too
Perfect.
aggressive and be like, I don't know if you know me, but like I got this TV show with
I'm
my BFF
famous. I have
Lisa.
a
You
LinkedIn
should
live
probably come
show.
on it. Yeah, but we're gonna ask him. I'll send him like a super sly LinkedIn message,
Nice.
and it'll be
Nice.
totally
Nice.
fine. Yeah, but
Perfect.
I met a lot of cool people. It was really fun. A+ situation all around. But yeah, the climate thing. I feel like we should get an eye on it. We should get an eye on it. Care
Yeah.
about it, maybe.
Yeah.
I don't like
Yeah.
being behind the trend. I don't like being
No.
wrong.
Yeah. I think we can get in front of this one. I feel like there's definitely still time. It's the biggest problem of our entire lifetime slash humanity. No big deal. Like massive, massive problem that's going to affect us forever and may cause the end of humanity, which might not be a terrible thing, but just saying it might actually cause the end of humanity. So we should care about it. You know, just an idea.
Did you seriously just say that? Did you
Yeah,
seriously just say that? You're like,
I seriously
oh
just
my
said that.
god, oh my
Yeah,
god.
yeah, yeah. I know,
I'm
I
I'm
know.
I have like a little bit more hope for humanity than you. I don't know. But anyway, the other
We'll
thing that's
see.
happening. Well, you've got some news. You talk about the news. You got the teledoc thing. What are you going to talk about?
Yeah, no, I mean, there's a lot of stuff that we can talk about, and hopefully our illustrious guests can also enlighten us a little bit more in these areas. But there's been a lot of interesting sort of merger-like news, like big stuff happening. So I think I probably said how much I admire Mark Cuban cost plus drugs for actually trying to reduce the actual cost of healthcare, not just move money around. Well, CVS, who obviously runs a massive PBM, made this big announcement about how they're moving to a cost plus model. I would be lying if I told you that I really understand the economics of PBMs. Like, it's definitely a very foreign language to me, but I can tell that they are trying to
It's
sort of
like PBMs.
draft off of
They're
him.
like the inky cool blackness. That's how I feel about. It's like you're in like you're not in like the
I'm
gray.
definitely
You're
like,
like in. It's like
trying to
it's you're in the
understand.
cold water in the dark. Like
Yeah,
yeah.
yeah, yeah, yeah,
Yeah.
yeah.
No, I
But
heard that announcement
they
too,
made
and I
a
was
big
interested.
announcement. Yeah, and I think first of all, I think I read that they are bringing cost plus drugs into their formulary. So Mark Cuban cost plus drugs are being added into the formulary, which is really great because he's really cutting prices. And then they're also moving their own reimbursement model to that. That makes a big difference for a lot of people. And so the details are going to matter. There's all kinds of issues here. I don't really know the whole story, but I think it is a big deal and kind of like I would say, without knowing much more about it, that the emergence and the initial success of Mark Cuban cost plus drugs is starting to move the other players. Also, like the pharmaceutical industry, like heavily lobbies against PBMs. It is they have decided that is their boogeyman that they are going to point to when anyone asks them anything. Is like, why does this drug cost so much? PBMs, PBMs, PBMs. So
PBMs,
they're like
PBMs.
they've decided that is like their boogeyman. And so it's kind of working, interestingly. We'll see how that goes.
I would have loved PBMs because I met that really charismatic PBM CEO from Puerto Rico at Hong's event.
Wow.
Yeah, and I was like, I love this.
Yeah.
I want to love PBMs. I love this guy, but I don't actually
Nope.
know. But
Nope. Nope.
well, you're right. So in any political, so I, we go. You are my number one news source, but I do actually like read the news myself sometimes. And so the Politico newsletters, like every morning, it's like the pharma lobby group is like,
Sponsored by
who's the
Pharma.
worst? PBMs. You know how
PBMs.
you have problems, America? PBMs. Yeah,
PBMs
it's pretty
cause all
real.
the problems.
Yeah. But I did hear about the CVS thing. I think that was in the Daily or one of the podcasts we both
Yeah.
listen to. So it cancels out the fact that I get my news there. But yeah,
Totally.
and the only thing I really understood in the whole thing was that they said overall they believed costs would overall decrease for most drugs sometimes.
TBD. We'll see about that.
TBD.
That's the
All right,
proof
should we
in the
move
pudding
to
if you can cut the cost, like actually cut the cost. Nobody wants to do that. Yes, let's move to our illustrious.
Let's get it going. All right. Here we have Hong from Define Ventures, principal at Define
Hi.
Ventures. I might be getting your title wrong. Who knows? We're not sure, but you can correct it. So as we said in our LinkedIn post, we cornered Hong at a health party, and we were like, I think she was like, I watched your TV show, or I know about it. We were like, oh really? What do you think? So here you are. Here you are. Welcome.
Yeah. Yeah. Well, thank
Yeah.
you guys. Well, excited to be here after our conversation. Like, ooh, I know this energy. I know this energy. I gotta be part of it.
Yeah.
All right, let's
Yeah.
go.
It's a vibe.
It's a
Yeah.
vibe.
But yeah, so introduce yourself, Hong, and as usual, we have no plan and no idea what you're going to tell us about, but we are ready for all of it.
Okay, cool. Well, I'll tell you about Define, maybe just to start. So, well, maybe even to go back before that, Kat, hello. We know each other from a previous life I had when I was at the California Healthcare Foundation. I was doing some really cool things in Medicaid for 4.5 years, one of which was data sharing, data exchange, and Kat and I worked together on some data policy things in California, which is big. And when Kat, you were at CMT, and I remember that first conversation we had, I was like, wow, she blew me away. I want to be her
See, that's
friend.
what I'm
Where are
talking
you
about. These are
from?
the kind of guests
Yes,
I like.
where are you
This is it right
from?
here. Love it. Love the ego back rub. I'm here for it. Thank you very much.
I'm getting invited back on more often, so I feel like I have to throw in some, some feel to you.
Yeah, it's fine.
But yeah,
It's fine.
was at the California Healthcare Foundation for a number of years, doing a lot of Medicaid investing before that, like some fun strategic things with Kaiser, with Cedars-Sinai, Memorial Care, hospital systems, California, all those things. And then joined Define last year. So wanted a bigger platform, wanted to see the world and have my opinion about what's right and not be tied to an organization that had its own incentives. And so that's what Define has been for me, and just like a wonderful place and wonderful people too. We've been growing. So we recently announced our third flagship fund plus an opportunities fund. So yay, $460 million. It just means we have a lot of
It's
work
like,
ahead of us.
Wow.
Yeah, I
that's a
know.
lot of money.
I know. I talked to an entrepreneur. He's like, what are you going to do with that money? I'm like, invest. We're so excited to be here. What are you talking about?
All right. Well,
So,
you let me and Lisa know if you need any help
oh,
with
yeah.
that.
Oh, always, always, always.
You can call us.
Yeah, always, always, always. And so yeah, I mean, we invest broadly. I invest broadly now too, but like in my heart is always, vulnerable populations, Medicaid, and then more recently, I've been spending a lot of time thinking about duals. And you're talking in your post about complex patients, and God, what an area of need. So yeah, I'm here to talk about duals. I'm here to talk about or anything else you want to talk about.
We love duels, right, Lisa?
Absolutely. And obviously they're what we hear from everyone else who is dealing with this on a day-to-day basis, or if you've ever dealt with this from a family member or a friend or anybody else, that there are still incredible, like fairly shocking challenges navigating between dual eligibility. Duals refers to dual eligibility for Medicare and Medicaid. Medicare, if you don't know, only covers 80% of stuff, and the other 20% you've got to cover some other way. And if you're very low income, you might be eligible for Medicaid to be your secondary payer. And these are two federal programs. Medicaid is kind of a federal state program. In case you didn't know, sorry, friends in the federal government, you don't talk to each other. You don't communicate. You don't have interoperability. You have you never the twain shall meet. How many times have I connected different members of federal agencies together to do something? Lots of times. So the programs themselves also don't coordinate super well, and it's a huge challenge to deal with people who are dually eligible for Medicare and Medicaid. That's my summary, Hong. What are you
Oh,
seeing in the actual like healthcare and health tech landscape for people trying to address some of these issues and help better serve dual eligible populations?
yeah, so I would say you summarized it absolutely perfectly.
Sorry, I've
She's
It,
seen it a lot.
smart. Lisa's smart. Sometimes it's perfect.
and so yeah, I mean that's the fundamental challenge, and I think what's exciting is policies moving towards this direction of
Yeah.
integration. I'm sure there are many opinions about how CMS is trying to approach it, but like I would say overall, for the patient's good. But it is so challenging. Well, I was at the California Healthcare Foundation, and we did all things policy in California, Medicaid reform, all these new payment programs. And my parents this year have been going through a lot. My dad just passed away recently.
Mm.
My
Oh,
mom's
I'm
in
so sorry.
homebound. Yeah, thank you. My mom's been homebound. They are both duals members. And I could not be a better person to understand what programs exist out there, who manages them, who pays for them. And yet it was an unbelievable
So hard.
process. It was me
Ugh,
on the phone with every
so
agency ever,
frustrating.
calling my grantees, calling my, all
Wow.
my CHCF relationships, saying like, does she qualify? Can she get into this, ECM, Enhanced Care Management Program? Does she qualify for community supports, this home-based program? And, it was unbelievable. And at the end of the day, what it really took for my mom to get the sort of long-term care services, she ultimately ended up in a nursing home, was, and I knew this from the beginning, but I wanted to do the right things, to go to the ED. When she went to the ED,
Huh.
then
Jesus.
Kaiser threw in its Kaiser powers and found my mom a nursing home that would take her longer term. And I, on the other hand,
Ugh.
little Dawn, sat there for hours calling all 50 SNFs in the county of Santa Clara to see if there was any openings. And like, I knew that, I knew all the programs, assessed her for every single one, and I couldn't get her in. And at the end of the day, it was that financial path there. And like, this is
Mm.
exactly what all these programs are trying to improve, like not be at the point where you get your care is the ED, and the ED is where everything like happens for you. So that was like, such a like eye-opening experience. Like we talk about the challenges of integrating Medicaid and Medicare and these services. And in California, it's, the progress has been slow. It's about 8% of, duals here are in any integrated plans. And then don't you get me in California and all its carve outs, but LTSS is still carved out that. So it's not even fully integrated.
Yeah.
And I don't want to even go down that rabbit hole, but there's just a lot to do. So like all these things moving in the direction of integration between Medicaid and Medicare, I think is absolutely necessary. And the things like I'm super excited about are like tools around navigation, business models, not purely tools, and then care models. Like we have in our portfolio MedArrive, which is a home-based care company looking at
Hmm.
high risk, high utilizers. And, throughout my mom's journey, there were so many days where they were just like, well, you should still come in and see your PCP, for a visit at least once a year. I'm like, do you
No.
know the
Are you
lift?
for real? Like,
Yeah.
no.
Like, how hard it is to get her into a car, how hard it is to, like, wheel her through the system, and that, like, I have to take time off, you have to coordinate all these
Yeah.
things, who's gonna be with my dad while she's out, like, it's not that easy. So yeah, that's what I'm super fired about and what's happening here and where I've been spending some time.
That's so cool. And honestly, like huge kudos to Define for bringing you on to work on that. Somebody who is having
Yeah.
actual lived experience, being a caregiver for, parents, for family members with dual eligibility, and actually having seen that yourself in real life. I mean, that's just super powerful for you to say, like, let me help, support and help grow, tools and solutions to address this. So that's really great for Define to bring you on and give that sort of focus there. I just think, this is one of those things where just like I will like scream all day about why is it that we accept basically no or very limited requirements around interoperability for Medicare, something that the government pays nearly 100% for. Same thing here. These are two government programs. Accepting that there is going to be extremely poor coordination between them is
Mhm.
just, it's ridiculous to me at this point. Not to denigrate the work. I also know the policy, structure and the programs that exist across CMS and other parts of HHS to do this coordination. There's a dual eligibles office. There's lots of focus at the CMS Innovation Center, but it's just like, why would we accept that? It is the purest example of like waste and, in my opinion, abuse of funds, and just this idea that we say like, oh yeah, well that's just how it works, the two programs, nothing we can do about it. Of course there's something we can do
Yeah.
about it. Like, of course there is. It's
Yeah.
not even a question, right? It's like literally the money is coming from the same bank account, and you
Mhm.
just kind of just say like, okay, like you should be able to make special rules when someone is dually eligible so we don't harm
Mhm.
them, like harm their families, like waste a ton of money, right? All those things are like real. We shouldn't accept that, in my opinion.
Lisa for
That's
president.
the platform.
Yeah.
Come
running
on,
on the
everybody.
platform of duals integration.
That's all I want
Yeah.
to do. If I just did that, I would be wildly successful in improving people's lives, actually. Like if that was my only
Yeah. No,
thing I
you
did,
would.
I would just like it would be a huge like plus up for everyone. But I would
Yeah.
need like
And
full
financially
power
too.
eminent domain. Like I would need like eminent domain, full power, like
Yeah.
unlimited authority from Congress. What do you guys think?
Yeah.
No? Yes?
Yeah. We could make you, yeah. We could just make you king of America. I mean, we could just do
That's
that.
right.
That'd be fine.
That would
That'd
be
be fine.
helpful.
But
I would always
so,
do eligible and I would leave and I would hand over my crown. But that's all I want to do. I
yeah,
just want
yeah,
to do that.
yeah, 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 yeah. Yeah, we'd have to abolish the monarchy after you left because I don't know if it would work after that, but that's
Exactly.
fine.
Exactly.
Un-American principles, monarchies.
Yeah, it would just be temporary. But so Hung, I think you illustrated something that, so not to make this the Chris Klomp show, but we're doing a little startup health class to some of their founders, and it's about working with Medicaid, right? Like how as a company, as a founder, how do you actually do that, right? Because we were pretty successful at Collective doing that, and part of what the point of the class is so often companies avoid working with Medicaid for exactly the reasons you just went through, right? California has an LTSS carve out. Well, how do the duals work in this market? What does the Medicaid plan care about in this market? And it's like super fragmented. So I'd love to hear like how you and your investment strategy, like how do you think about that? Like, are you just like, whatever, it's easier to Google? Because that's what I tell people. But like, how do you approach it? I'm like, yeah, just, or call Lisa, right? That's what I
Yeah.
do.
We yell at
Well,
them.
well, that's also a really great strategy to call Lisa.
Yeah.
I've definitely done that at CHCF too. It's really hard. And what you need in venture is scale, right? You need consistency in markets and you need clear payment models. I think when saw you guys, I was like, the high horse I was on was like, make it the same, make risk adjustment the same, make these policies the same, make the rates the same. Like people shouldn't have to guess as to like how this whole
Yeah,
system works. Just fundamentally
I agree.
cutting people out from the outside, right? Innovators, people need to come in from the outside. And again, and sorry to be sort of a one-trick pony, but that's where the duals market is a lot more interesting. You have fundamentally at the bottom, at the end of the day, the medical spend comes from Medicare. It is a national program that we all understand. And then the Medicaid stuff gets extremely messy really quickly, but you start with something consistent and big. It's a small percent of the population, but they're the most complex, most expensive. So you're still controlling a lot of dollars if you're starting with the duals population.
Right.
So, I really encourage entrepreneurs who are thinking about population-based programs, especially in Medicaid, is to think about what populations and what markets there is some consistency. Whether you're working with the SSI population, understanding which states actually cover it. If you're working with the TANF population, what states actually cover it. So that's how you should be thinking about your markets in Medicaid, and then trying to find some consistency across all of these at the basis. But I would say like duals is just a really nice place where you have the cover of a big national program whose rules, and I wouldn't say any people understand it, but is at least consistent.
At least it's like set in the
Yeah.
same, more or less.
Yeah.
Yeah.
Yeah, so that's where you have to go find scale. There's a lot of one-offs in Medicaid. Like people talk a lot about the 1115 waivers, which are great. Like so glad we're trying things, but to build a business off of a program that may exist, may not exist, may transform in the future is really hard. And and then all the other nuances of a 1115 waiver program, right? Yeah, some of them continue to stay on, some don't. And again, glad we're doing it, but look for consistency in these markets because that's where you really need to go.
I'm glad you brought that up because there are a lot of big waivers that are either just coming into place now or being talked about and negotiated probably with CMS right now. So from CalAIM here in California to big waivers happening in New York and elsewhere. They're big enough that they do seem like they would be market movers, but your point is like, hey, that isn't guaranteed to be around forever, whereas the dual eligible system
Mhm.
it's not going anywhere immediately. So I think that is interesting. That's an interesting point for sure.
Yeah. I mean,
Yeah.
I'm looking forward to see, like in California, we've seen so many waves of this. There was the health homes, which sort of evolved into CalAIM and so many
Hmm.
programs previous to that. So I think I would think about them as like reading the tea leaves as to where state Medicaid agencies are trying to go. So if you're roughly in an area, have an opinion, like if it's SUD, if it's maternity, having an opinion, just seeing where there's consistency, and then using these entry points, these wedges with these programs into like getting into the core business. Like what is their like
Mm.
how are they paid for? What are they fundamentally incentivized? That's not sort of a an innovation program, and using that as a way into building these bigger national or bigger, at least statewide contracts.
Nice.
Yeah. Yeah.
Well, the venture world right now is, especially for health tech, is looking a little bit shaky.
Mhm.
Kat, as we all know, has been waiting for a long time for the long cold
Long,
winter.
cold
She's
winter.
very excited.
I'm ready.
Um, seems like you are, and Define is in a different position. So, like, what is your outlook right now? Seems like you guys are a lot more
Yeah, you're on the
optimistic.
beach. Hung's on the beach.
Oh my God. We're
I've got my
good.
fur hat
Right.
on.
She's like ready. She's like in Poland, like drinking vodka and
I'm ready. I'm
in
ready
their
for
long.
it. Yeah, but
Yeah,
Hong's on the beach. So yeah, I want to hear about how's the beach.
yeah. I think the fact that we raised our fund is just a good sign. We always think about ourselves as sort of being like an early indication of where this industry is going. It has been a strange time, and it's been a strange time it's because 2021 was a strange time. Like I don't know if it's a strange
Yeah.
time because it's like it's actually saying anything about the industry. I think in 2021 we had a lot of money because of just where the economy was, and because of COVID, people seeing a lot of opportunities and like really big changes, and investors making a lot of big bets that were unreasonable at the end of the day. And now 2 years later, we're sort of seeing the results of it. So yeah, would I
What
say that
happened? Yeah.
right? Would I say that we're in a cold winter? I'm like, compared to 2021, yeah. Compared to like 2018, 2019, and like where we probably should have been in the industry, probably not. Like the
Hmm.
trends are still there. There's still opportunity, and we certainly see that too. And it's really different. Like what we see is different whether we're looking at companies in the Series B world versus in the seed world. In the seed world, I think there's still a lot of interest, still a lot of money to invest in this. In the Series B, it's this all the companies that were formed 2021 and prior that are sort of coming back around. Have like made that money last for 2+ years coming. And so like in 2024, I think we're expecting to see a lot coming onto the market. So I think it's I wouldn't say it's a I would say it's very much just course correcting where 2021 is as opposed to this cold winter. So I'm sorry. I don't know
Sorry,
if I
Kat.
All right.
really
Listen,
waited.
I've been ready. I've been ready for since 2013, as everybody knows. So I will just be ready for a little longer. It's okay. It's not a problem. I'm okay. Well, what do you think? Okay, so like talking about the CalAIM and the New York waiver that everybody's been waiting for since ever, right? Or at least April or May. What do you think about the whole more attention on community health workers and technologies that work with, deploy, coordinate them?
Mhm.
Is there opportunity there, or do you think that's more siloed with those like the waiver markets?
I think it's really exciting. One of the reasons I wanted to be at CHCF in the first place because I think healthcare, of course, and this team, you all know this so well, but it's so inextricably tied to policy and policy changes. And I think this is a really good one. This is, CHCF has been pushing for, licensure, payment model, like a formal sort of career path for CHWs for a very long time, and we're finally getting there. I think it is an important and necessary part of the ecosystem. So I always think about businesses in at least two ways. It's sort of like vertical, horizontal. Whether if you're vertical, you're sort of the whole service. Like maybe you are the management of CHWs, maybe you are CHWs at the core of your like clinical model, and you're selling sort of bigger volume. And I think like bigger dollar, I call them big dollar, small number types of businesses where you're, either managing the full primary care services or just, the full services themselves. And these are big dollars. So I think CHWs are a really great component of that. And I think because healthcare is so local, I think this has just been like a fundamental missing piece of the care model for a very long time. And then the other way I think about it is vertical. So, selling tools into for CHWs, I don't know if that in itself is a market that's big enough, but CHWs aren't so distinctive in what they do. There's a lot that is, very critical and necessary, but there's some things that they do that others do too, right? Like social
Mm,
workers, things like that. So like thinking about the market much more broadly in terms of
yeah.
tools and how you serve CHWs, and that CHWs being a piece of that, I think makes a lot of sense. And that continues to be a really big trend. And like what I was saying, the care coordination, the navigation, I think they're increasing incentives and reasons for people to be engaging members and like giving them a much better experience in the world of value-based care, changing CAP scores, things like that.
Well, there's the Community Care Hub program. So a number of Civitas members have like been able to reach that designation of Community Care Hub, and some of them, like Health Impact Ohio, have created these training programs and certification programs for CHWs. And I think I like what you're saying with regards to the sort of specific designation. I do think like there is no, and I will hear about probably really soon from our next illustrious guest around the workforce challenges. Like there's no magical solution. We're not going to magically create more doctors and nurses and other clinicians. So we do have to find ways to use and build up and equip other people in sort of the allied professions or in the community health worker, social worker kind of level to serve those populate. Like I don't like there's no other magical way to like create more people to deliver care because we need more people to deliver care.
Yeah.
So I feel like it's got to be somewhere in this overall solution, but I don't know the exact balance or what has to go into that.
Yeah, I think we've been living the dream or trying to of practicing at the top of your license for a really long time. So still waiting
People
for that
say it a
to
lot. They
happen.
say it a lot.
I
It,
still
I
don't.
don't know. They say it a lot.
Yeah, I've not seen it happen at scale. I've seen it happen like within specific care models where you're like, you're gonna. The state says you can prescribe medicine now. You are gonna go
Go
prescribe
for
medicine.
it.
Yeah, go. And we're gonna like give you some training and oversight, but you're gonna be able to do that now. And I think that's really great. But like the the scaffolding, I think, still
It
needs to be there.
It
Mm.
depends, right? I mean, I think I don't know for sure. Obviously, again, probably someone who's more qualified could tell us in the comments, but I would suspect that kind of the most, if you're just looking at scale, like depending on the state, probably more advanced practice nurses are like not practicing at the top of their license as they could be in most states, and then secondarily, probably PharmDs are like totally being underused, just like like
Mm.
you work at CVS, have a nice day. You're like, no, like this person went to school for like 12 years and like really deeply understands these issues and can be doing a ton of care. But there's not like enough other support around them so they can actually do
Yeah,
that and not be totally burnt out. So there's just like tons of there
it's
are a lot of groups of clinicians who are not really being able to practice at top of
yeah.
their license.
California just passed the law policy recently that enables PCPs to actually practice in NPs to practice independently as PCPs,
Right.
which was huge. And it's also like, who is going to do that? Like they have in such for so long practice within a system that like what does that mean for them? Like what kind of support background? What does it mean to practice to completely like independently solo? In a way that you really move the market, right? That like more of these MPs are truly stepping into this void that of like the PCP gap. So, I mean, that's an area we think about a lot too. Are there enabler models? Are there sort of like franchise-like models to support PCP MPs in moving in this direction? And for a lot of these different, again, I don't think this practicing at the top of the license thing just happens. Even if you move the policies, it's like how do you build that scaffolding and training
Hmm.
along the way to like really get the workforce there?
Well, and and obviously, like the various medical specialty societies, including the American Academy of Family Medicine, don't necessarily agree that that's the right solution. I think a lot of them say that you need to make primary care more attractive. That's a longer term goal, certainly.
Mhm.
Not going to happen overnight. It takes a long time to train any of these professionals, right? Like it's not like you just like again like press the button and they come like walking out of a
Yeah.
medical school. It takes a long time. And so, there's all kinds of options here. There also are, increasingly physicians who are moving into fully independent practice,
Mhm.
and being direct primary care providers. There's a lot of different solutions, but I don't see like a blueprint or a path that's really being picked up by a lot of different parties. I think we talked about this in a previous instance of the Health Tech Talk Show, previous episode, about wasn't it UC Davis that is really investing in actually getting medical students from the community who want to stay there. Like
That is
and they
so
have like
Yeah.
a huge level, like way more than other medical schools. Like that's just one of those like kind of obvious ones. What I have heard is that the areas where there might be nurse practitioners who are willing to set up independent shop are again like really rural, remote locations. But again, like where's like the blueprint, the map, the support, the everything that has to go along with that? You can't just do that and just like out of the blue.
Yeah.
Um,
Yeah.
so
But I will say,
yeah,
like, step one is just making it possible in the first place. And then step two, maybe that's, the role, defined in others like us in the funding environment. Maybe it's, our, hospital system partners, payer partners that are thinking about, regions where there's really unmet need and like trying to create a strategy and really focusing on supporting those populations in that way too. So, I hear you. It's so easy to be pessimistic in healthcare, but I'm like, great. Or at least it's one tiny toe in the right direction, and like let's
Yeah. Incrementalism. And we got a comment here from Brittany. I'm going to pronounce. I see all these people's names online, but I've never pronounced them live. So Brittany Boosie, maybe, just
maybe.
spoke to an independent PharmD assisting her local primary care physician with community primary care needs. Love to see that expand. Yeah, absolutely. I know there are some really cool. I won't call them pilots, but case studies where that's been super successful, especially in rural communities. But we are seeing a lot of pharmacies go down in those communities. But that's a topic for another show. So we do want to get to our next guest, who is going to talk to us about the future of work for healthcare workers. But Hong, what parting thoughts for our massive following of health tech viewers?
I would say, we hear Define are clearly still enthusiastic about where the market is and the opportunity out there. So, there's a lot of whispering and talks of cold markets. We're not feeling that. We have our heads to the ground in
On the
terms.
beach.
Yeah, on the beach.
On the beach.
That's right. And so, I still think there's a lot out there to be really excited about and the progress that we've been making here in healthcare.
Awesome.
Nice.
Awesome.
And where can people find information about what you do on?
Yeah.
We'll share it. We'll share it afterwards. So we'll
The
put
internet.
it in the comments.
Yes,
The website, the internet, Define Ventures.
Yes,
.com,
definevc.com is where you can find us. And I guess you can always find me in all the places. LinkedIn. I think if
all
you
the
Google
places.
that, there aren't too many people. If there aren't too many people with my name in healthcare, so you can just try that.
We'll put it in. We'll put it in our show notes tomorrow. So
Okay,
thank you,
great.
Hong. You're the best. Thank you. Thank
Thanks,
you for
Hong.
letting us corner you and convince you to come on our show. You're the best. All right, let's move to the intrepid, incredible Curtis Anderson. Oh wait, yeah. sorry. It's been a long night. I had a long night, Curtis. I know. Listen. Yeah, I know. Holy shit. CEO of NERSA.
Quite the Friday.
Welcome. Yeah, I know. Yeah, so welcome to the show. So I do want to start out by saying, so Lisa is technically my boss at Zoria because she's on my board, and I'm learning that nonprofits mean that you don't get to be a benevolent dictator. So she's both on our board of directors, and we actually can't ever remember if she's vice president, secretary, and treasurer, or just one of those things. But it doesn't matter. The point is,
I'm not sure.
I'm a CEO. It's the best. So most people have heard of Zoria. So it's a public charity 501c3 that I started like in 2021. We give out cash grants to women working in healthcare roles for childcare and caregiving. And Curtis and NERSA were so kind to match our Giving Tuesday campaign up to $10,000. We crushed that goal. Everybody knows that.
Nice.
So we raised $25,000 total. Thanks to a last minute gap fill by Lisa to get us exactly at 25K. And so we're going to be able to give out 25 additional grants before the end of the year and get some money in some nurses and other healthcare workers' pockets. So thank you, Curtis, for that. But we'd love to hear, just introduce yourself, please. Tell our audience how cool you are. Maybe drop a good joke. I don't know what's going to happen.
I am a dad, so I don't know if I can strike
Oh,
good jokes. I've got dad territory pretty well down pat. Grateful to be here, and thanks for the time. I founded Nursa.com, which is a two-sided healthcare marketplace platform that helps connect managers who have shift needs in a unit to nurses who have the qualifications to fill those shifts. And a fairly simple idea on the forefront. But history in this sector has been quite an educator and incredibly complicated in the way that workforce logistics have happened and contingent help has been found historically. And so we have simplified the equation.
Yeah. So
Nice.
obviously we all know that we have a massive healthcare worker shortage across the board, right? And there's a number of companies trying to figure that out. The feds have put a lot of money into like public health worker stuff, right? All that stuff takes time. And what I really am into about Nursa is one that you started really in the post acute space, right? Another area of like massive need. So I'd love it if you can talk about like that and where you see y'all going and why.
Yeah, certainly. It's actually much more nuanced because if you talk to certain groups today and look at just quantifiably how many clinicians there are, it's a little bit different story. There is a
Totally.
chance, there is a chance that there's enough there, and so how they are engaged, the way in which we think about work more than workforce certainly starts to come into sway for the discussion, right? And certainly you'll hear both sides of this coin pretty aggressively debated. How short are we? And no, we're not short. You just aren't reaching us the right ways. And that for me is part of what was an illustrator that there was an opportunity to not only have a discussion but work to find viable solutions in this case. I generally tend, just listening to Hong, I generally tend to fall on the side of the fence that she does, in the fact that the future's optimistic, right? I mean, this is there are certainly ways that we can
You're
solve
also on
this.
the beach, Curtis.
You're
You're
also
also
on
on
the
the beach.
Indeed.
You're the
Got
only
it.
Every
person
day.
Everybody's on the beach
snowbank, Kat.
except
It's
for this
just
girl.
you
You know what?
in the
Well,
snowbank.
if it starts snowing on the
But
beach, I'll be ready.
no, but here's the thing about that, Cat. Like, it's certainly a valuable perspective, because the contrast is what will drive change, and especially as we talk about technology's evolution in healthcare, right? The one side of the token, and Lisa, you talked a little bit about this already today, but there's is this critical bent that we don't move fast enough, we don't adopt quick enough, we can't open channels fast enough or fund things thoroughly enough. Okay, that's fine. On the other side of the token is we have all the opportunity in the world, right? And in most cases, when looked at or compared to other industries, we're adopting patterns of behavior, principal ideas that have already been proven out elsewhere. And so, wise is the man who learns from his own mistakes, and intelligent is the man who learns from the mistakes of others. So you've got some potential there. And I actually think right now, a really great example of this, where leapfrogging could be really valuable, is AI, right? There's a chance that we could tackle data interoperability much differently than has historically been thought. And if you look at other industries, there's this whole segment of evolution where moving data, transforming data, there's whole careers that have taken place in
Right.
that. But if we structured this well, I think there are some components where AI or machine learning, the augmentation of those processes with forward-leaning tech could offer some incredible and very impactful solutions that wouldn't require 20 years of development in another thought process. you see this. I would for a bit. I traveled quite extensively. You would see internationally. One of my favorite illustrations of this. We were in on the west coast of Africa, and there were these stop posts every 3 or 4 miles down the road where you could find a 110 and a 240 outlet, and you'd get your electricity, and everybody would walk to those posts to plug in their phone so that they could pay their friends through a text message. And I just
Yeah.
think the idea of that, like, there's a place where we're still trying to get clean water or uh, move electricity. And oh, by the way, I pay all of my bills on SMS. And so to watch some of these
That sounds like the
evolutionary.
US. That sounds like the US minus the pay all of my bills by SMS. We have plenty of places in the US with no
No,
clean
that's
water, crummy
yes.
electricity, crummy infrastructure, and we pay via a paper check from the 1910s.
And now you've got a friend who is not on the beach. That's the ticket, right? Like there certainly is some benefit to proving something out elsewhere and then adopting it as fast or as quickly as we can. And the majority of this is focused on clinical care, right? So you don't want to take, like, there are serious things to contemplate about the risks that you're taking in those settings. Lucky for us, like, this is not so much a clinical disease or challenge. Like, we're talking about logistical and operational challenges of the same order.
Hmm.
And for us, that's exciting. Like, there is just an seemingly endless horizon of potential of how to impact so much of this. I was speaking with a nurse yesterday and talking about the difference between optimizing the nurse or their time with optimizing everything else that eats up their time, and the differences of those two approaches, and how we can be helpful in providing the maximum amount of potential time that they could impact and spend with patients is fantastic. I think the future's for the faithful, and we'll welcome you on the
Ah,
beach
Ooh.
anytime.
ooh, yeah. Listen, I might show up sometimes. I might get cold. You know, it's hard. It's hard being cold for
Certainly.
that long. Um, so I like what you're saying. We had a guest on a couple of weeks ago, Solome Tibabu, who runs behavioral health tech, and is super focused on the behavioral health tech space, obviously, given the name of her organization, and said something similar, right? It's not about like replacing clinicians, right? It's about augmenting, simplifying, so that they can spend more time where they actually want to, and where it's most useful, which is typically, client facing, or not. I'm client facing. I'm about client services, patient facing, patient services, and getting that face time. So that's awesome. I think that's great.
Yeah.
So talk to us. So I want to go back to what you and Lisa were both saying about health. We actually probably have enough healthcare workers, enough nurses. It's just that they have decided that the way that they were. I think about it like air traffic controllers, right? Like, their jobs are miserable. Right, like, they're dropping like flies. They're retiring. They're burnt out. Like, objectively is it's a terrible job, though very important, right? And we need many more of them. And so it seems a lot like that to me, right? And that's one of the reasons I started Zoria Foundation, right? Is because you look back, and at the
Mm.
time, these nurses many of them were leaving their children with relatives, not seeing them for months because they didn't want to get them sick, and there was really no support for them. And it was just kind of like, hey, do your job. So I'd just love to hear your
Mm.
perspective on how you see that, and then how NERSA is solving for it.
Absolutely. In a vacuum, efficiency wins. So, what we're interested in helping to create is the digital switchboard that maximizes the potential for those connections to happen and deepen the relationships at work. Um, I'll illustrate this with a slightly different example than childcare, but it still paints the same picture and is certainly a part of the calculation. We talk with nurses and CNAs, LPNs every day, right? That's the
Mm.
main faction of one side of the market that we serve and are partnered with. And the stories are just incredible. I met a gal, Brianna, who had worked for a facility group for a number of years, 6, 7 years, to the nature of some of your earlier comments, was practicing at the top of her license in an ICU, loved the team loved her. At length, Brianna's mother develops disease, late stage in life disease. She wants to leave to care for her mother. And there's a quandary here because the team on which she works is dedicated to patient care. The facility is short. There's an average for the facility of 28% vacancy, which is heavy. And that team needs to be able to focus on the patients. But Brianna can't meet a full-time schedule. To the facility, it's not valuable if it's not a full-time schedule. And so Brianna leaves. Brianna goes to take care of her mother and starts picking up shifts on the platform, is able to get her problem solved. Now, meanwhile, the facility group is not utilizing a layered solution. So they've got a float pool, but about 85% of the team, Brianna's manager, for better than 3 months, fills her shifts, fills the shifts that Brianna would have been filling while they hire a full-time replacement. Now, that to me it's fascinating because on one half of the discussion, there's this, we have so many needs, we need full-time help. Like there's no argument that that's a reality. But Brianna, if the platform didn't exist, like would have had to go to a different industry to find flexible labor opportunities that were deep enough that she could take care of herself, take care of her mother through that period of time. We will see situations like this on a weekly basis as we're visiting and talking to folks. And what I think this helps illustrate about the work that Zoria is doing and where it is impactful is that childcare is one of those calculations. Like you can't solve for this every day in a consistent pattern well enough to be predictable. And so you've
Right.
got this thing that forces, in some way, forces your hand to make choices that you need to be enabled with a greater degree of flexibility. You've got to drive, and to have somewhere to go to fall back on, find help with, be enabled by childcare assistance is material. I only knew and recognized the problem as we had discussed it because I have seen it in lives. Every time we go to find people, like this is a very, very common trend, and the help is certainly needed, and so it's good work.
Yeah.
I mean, it's one of those things where you can talk all you want about there being workforce challenges, but if you're not willing to actually do things or create programs or actually provide help, then you might as well just not waste anyone's time, right? Like it's an obvious one that you can't get around for a lot of people, right? I mean, it's
Yeah.
just, I completely agree. So
And
annoying. It's so annoying.
And there's nothing enticing about trench warfare, right? And that's a poor metaphor, but nobody wants to go do the hard things, right? Like this is a really hard thing. It's an emotionally entrenched problem to solve for the individual who's facing it. It's systemically impossible to start lining up and doing those matches. And so in many cases, it's a circumstance that may not have even been borne out by personal decision, right? You've landed here, and that can just be frustrating to have to walk up that hill every day in navigating life. And I think it's incredible that there are opportunities to create impact here. It happens one at a time, which is so material, right? There's that is a story in and of itself. Every dime goes through to an individual. That's massive, and certainly a valuable part of the play. And so now, I mean, I have a couple of questions here though about how you look to scale and structure. How do you grow and create additional? where does this go from here? Because the tests are certainly working out, or the use cases. Like, you're seeing value in some of the stories that I've heard alone, but where do you take it from here?
Yeah, I mean, I think that it's interesting what Lisa was saying, and what I think you're saying, like what's next, like what do we do now? It seems to be working, but there's still some resistance to change. And I do love our great healthcare provider organizations, love them as much as I love our great federal government, like all things. But what's interesting about how you're framing for what you're doing is you're really talking about how this helps an actual individual, a healthcare worker, a nurse, a CNA, whatever it might be, whoever it might be. And that's interesting. And I think often the way this is looked at in the industry is it's from the perspective of the healthcare provider organization, right? And oh, is it too expensive for them? Or oh, is it too hard to have flexible work arrangements, right? And I think if we do care about the future of work for healthcare providers, then I think we have to look at it from the actual worker's perspective.
Sure.
Ooh,
Sure.
that sounded a little bit, that was a vague, almost socialist statement from you, Kat McDevitt. I know you didn't mean
Oh
that.
shit! Yeah,
Sound like me now.
I had a rough night. My empathy must be
Yay,
coming out.
workers'
I don't know.
night.
It's weird.
Go
It's
workers.
weird. Yeah,
Well,
yeah. I
welcome
don't know.
you to the beach.
Welcome to the beach,
I
Kat.
don't know. I enjoy being a little bit miserable. So I'll get close. I'll see how it goes. But yeah, I don't know, Lisa, what you think about that?
No, I mean, yeah, I always am looking for people who are actually putting their words into action and making changes, making policies, and then putting them to actual action. I'm waiting to see that as well. Like, I'm waiting to see that. I am still waiting to see someone really making a move that actually addresses some of the challenges that people in the healthcare workforce have beyond needing new information and training, but actually like, structures that work, jobs that can help them, policies and pay and structure and flexibility that can actually help them do their jobs. So fingers crossed we get
Yeah.
there. But I like what you guys are doing for sure.
No,
I like the advocacy too. We need more of that.
Yeah.
Yeah, I certainly think that, look, like a majority of what we do will list, match, and fill within 24 hours of the shift start time. And so, in a very real way, I share this with the team often. We make changes today in code that impact the way somebody's going to get care tomorrow. And in some cases, the fact that there will be someone at the bedside to provide that care, period. I love that. I love that. And I think, sometimes we ring a pretty trite bell around this idea of that healthcare is different because of the impact of our work. And if we're not careful over the course of our careers, it can become a very casual statement. It's important to remain active and have conversations with the folks who are doing this. And for us, it's material for the business and operational plan and strategy that we're deploying, which is there's twofold there of just real goodness. Like, it helps remind us on a daily and weekly basis of why we're here, and certainly helps us dig in when the challenges get tough, so that we can get there. Mountaintops are small and the air is thin. So you gotta make it count.
I'll put all these in my pocket for later. I love it. I love it. Well, Curtis, we are almost out of time, and allegedly LinkedIn cuts us off right at 5:30. But give us a good one-liner to put in the pocket with the others.
Let me
Pressure.
see here. One of my favorite. We'll get you on the beach yet, Kat. One of my favorite individuals I ever met. He was 97 at the time I met him. He would say to me all the time, "Curtis, everybody's good for something, even if it's just a bad example."
Oh no!
And that, like, to get to that point in your life and still be that optimistic about what is ahead, I think the man deserved a medal. He was a remarkable individual, and I have taken it as a philosophical foundation that, look, like, even at that point, you've provided value in somebody else's life. So just live on that edge.
Amazing.
Yeah. Wonderful. Well, thank you, Curtis.
Thank you,
you to
Curtis.
our
Likewise.
loyal followers. Thank you, Lisa. Thank you, Melissa.
Thank
and
you to
thank you,
Hong.
Hong. Yeah, we're gonna switch to our end here. And thank you all, and happy weekend. We'll be back next week.
We'll be in DC for the ONC meeting.